briefly, ankle brachial index or ABIs. Again, blood pressure cuff at the arm and at the foot, and usually we use a Doppler. But a crude way to do it is with an automated blood pressure cuff, that you can just put here and here and compare the two. And you're basically taking the highest pressure and dividing and getting a ratio. So anyone with an ABI greater than 0.9 doesn't really have peripheral arterial disease. There's a caveat here. Patients who are end-stage renal or diabetic have calcified blood vessels. So they're going to come to you with obvious signs of PAD clinically with a normal ABI. So you know right there that it's because the vessels are too calcified. It requires too much pressure to constrict them. So, anywhere below this is mild to moderate. These are the patients that if you manage them appropriately, statistically and in the studies, the likelihood they need something done in the next 5 to 6 years is actually quite low, but that's dependent on appropriate medical management. And then when you're talking about below 0.4 or 0.5, we call this the critical limb. You get rest pain at 0.4, gangrene at 0.3, and if you're following this in the office, anything that changes 0.15 is something significant, so something is getting worse. Some medical risk factor or something that the patient is doing or not doing needs attention. Critical limb ischemia, if you're in this category of patients, these are patients with rest pain and gangrene. This is an urgent referral. That's because the outcomes of patients with CLI is pretty poor. You can see that 20% do die within the year, and if you survive, 40% with an amputation or some tissue loss. Toe pressures are like ankle pressures, but they're done at the toe with tiny cuffs. These are good for patients with non-compressible vessels. These are patients who are diabetic or end-stage renal. The toe, the blood vessels in the toe are less susceptible to that calcification, so you get a more accurate reading. Normal toe pressures are 20 to 40. Anything under 0.7 is abnormal. And typically, I kind of keep this in mind. If I see a patient that's, less than 30 with a toe wound, probably not going to heal without some intervention. 30 to 40, likely to heal, non-diabetics. Greater than 40, it's worth a shot with conservative therapy, medical management, offloading, and with appropriate risk factor management, they may stay out of the operating room and actually heal the wound. Treatment options, medical management, supervised walking program, which is a reimbursable thing for, so it's recognized. Typically when things become reimbursable, they become legitimized, but really it's been recognized for a long time that walking is good for patients with peripheral arterial disease. It stimulates collateralization, continued surveillance is critical. Endovascular revascularization, that's catheter-based techniques. Open revascularization. Sometimes you get in the lab for an angiogram and you find that their entire SFA is out. Sure, you can spend some time getting that open and balloon it and stent it open, and everyone pats himself on the back because it looks great, but the likelihood that it's going to stay open is quite low, and maybe the patient might be better off with a surgical bypass. So, and that's where that sort of combined technique comes in. If you have an eye for things and have a wide skill set, you can offer the patient the best option. Venous insufficiency is another reason why patients may come in with similar symptoms. Basically, the initial workup for venous insufficiency, you want to know about leg swelling, aching, cramping, tingling, and restlessness. And these symptoms are going to be worse at the end of the day. So the patients will say they wake up in the morning, they feel great, their legs look great. By the end of the day, they're having all these symptoms. And actually, this is relieved by walking and elevation, unlike claudication, which is going to be worse. And that's, again, where that history is really important. They're going to have family history of varicose veins, smoking history perhaps, hormonal therapy, DVT history, standing for long periods of time, history of wounds, ulcers, or patients being admitted for cellulitis. And then another thing that is venous insufficiency, more proximal, more central. Patients may complain of pelvic heaviness, hematuria, painful intercourse, and that can be pelvic congestion syndrome. Physical exam, presence of varicose veins in the pelvic area or legs, swelling, and then knowing whether the swelling is localized to the legs or generalized. A lot of times we see patients, again, with swelling of the legs, but their swelling is generalized because they've got poor EF, or they've got liver dysfunction or kidney dysfunction. So, kind of localizing where that swelling is, and then looking whether or not, this is sort of a loose finding, but looking whether or not that swelling involves the top of their foot. That's more of a lymphedema type picture. It doesn't mean that they don't have venous insufficiency, but what it shows is that there's a mixed picture there, and that patients may not have the best outcomes if you were to offer them just strictly a venous treatment plan. And then again, skin quality and any changes that they've had. The superficial veins of the leg, there's two main truncal veins, a greater and lesser saphenous vein. A lot of the varicose veins and spider veins and reticular veins that you see are all tributaries of this. So our therapies are targeted at the truncal veins, that reflux. And again, we're talking superficial veins, not the deep veins. The deep veins, obviously, you want to preserve. We have perforating veins that connect the two. And essentially, this is, blood is obviously traveling against gravity, so we have valves inside, and when these valves work, they prevent blood from pooling and refluxing, and it's only when these valves break down that you get what we call venous reflux and engorgement of the veins. At rest, your hydrostatic pressure down in your foot is high, and as we walk, it drops. This is normal, and this is what we want. This has to do with the calf muscle pump. This assists in emptying the veins out of our legs, and that's why walking is good and is prophylaxis for DVTs, because you're squeezing that blood out and not letting that blood be static in your legs. What can you do in the office? You want to evaluate the patient first and foremost for an arterial issue. There have been times when patients are being treated on a venous pathway and just not healing and not doing well, and they don't have pulses in their foot and they've got bad PAD. So you always want to treat the artery side first. If they've got good palpable pulses and you're confident this is venous, you can prescribe graded compression stockings. You want them tighter here than up here. They come in different grades. I always tell patients, if you're going to buy them online or at the store, make sure there's a number attached to them versus just medical grade compression, because you really want them tighter down here than up here. And then getting a venous insufficiency ultrasound and making sure you use that language in your diagnosis and in your order, otherwise you'll just get a DVT study. A DVT study is already part of a venous insufficiency study. So if you're looking for venous reflux, order the venous insufficiency study, and then make an appropriate referral. So when we see these patients and we've managed them medically, and they've, for whatever reason, maybe can't tolerate the compression, or don't want to wear them in the summertime, things that we can offer, and what we do now on pretty much every patient that has this issue that meets the criteria is ablation versus vein stripping. And so the other thing we do is sclerotherapy, and that's injecting sclerotic medication to get rid of other varicose veins. The other thing we want to do is also work up patients for any type of blockages that may be more central. And these are patients that may have had prior ablation therapy, come back with a recurrence, or are not having good results. This is what I was alluding to before about more central stenosis. Just by the nature of our anatomy, we can have stenosis of our left common iliac vein, by the way the artery lays on it. And so it can increase your risk of DVT. It's mostly affects the left leg. Where this sort of fits in the algorithm is when you see patients with venous insufficiency, I tend to treat their peripheral insufficiency first, make sure they don't have, obviously, an arterial issue. If they don't improve or have some recurrence, looking at more centrally, perhaps this is the issue. And if you've treated them both ways, then you can sort of kind of reliably say maybe this is more of a lymphedema picture. Kidney dysfunction, this is kind of a general thing a lot of our patients do. The point of this slide is just to say that, in part of our training and part of what we do is placement of access and management of that access. And you don't want patients to crash on a dialysis. You don't want patients to come in emergently and get catheters and catheter-related issues. So if you are following patients in the office with CKD, I'm sure either you're managing that or you're connecting them with a nephrologist, but being mindful that having an access discussion sooner rather than later is going to be beneficial. And again, yes, part of what we do is we place fistula and grafts, and then we can maintain those as needed, and it's just a continuity that we prefer as surgeons. So in summary, vascular surgical care actually starts with the primary care physician. Identifying and initiating appropriate workup saves lives and limbs. And we're here to support you in your practice. We just want the best outcomes possible for all our patients. Thank you.
Anyone have any questions? I have a couple. Hey, so Sheraz, can you explain to the whole group, because some of them, podiatrists and internists and as a whole, they may get blue toes. You kind of alluded to it earlier with the emboli and how they may actually have gangrenous lesions on their toes with pulses. Explain that.
Sure. So if you have patients, so the question is about blue toe syndrome and gangrenous lesions on the legs and kind of how to work that up. A couple of things, when you see acute onset blue toe or wounds developing on the distal parts, at the tips of your toes, you're worried about emboli, either from a proximal source like an aneurysm. Alternatively, patients can have bad atherosclerotic disease, and they can have debris that's embolizing. So, those patients are critical. You don't want them to go in a situation where they either shut down blood flow and become an acute situation. So, making sure that you stay on top of those patients, and if you see something like that, managing them, medically, maybe getting an arterial ultrasound, and making sure that you get in touch with vascular specialists.
Yeah, the one thing that with blue toe syndrome which is odd, is that they may have these gangrenous lesions on the toes,
right?
But they all have pulses. And you're like, why is that? So in order to get these emboli to the toe, they have to have open highway. And you'll say, well, that doesn't make sense. And so that will key you in to either looking for an abdominal aortic aneurysm or even popliteal artery aneurysms. It's just something that sometimes I get to send these patients for this, and they think, oh, it's just peripheral vascular disease, but I get there, they got pulses, and the first thing I do is I get a CAT scan of the belly with runoff to take a look at the popliteals also. So that's just, it's more common than you think, and that's the one time I'll repair an aneurysm in the stomach that's less than 5, a lot of times even
right.
4. The one other topic you brought up was the pelvic congestion syndrome or varicosities in the groin region rather than just varicose veins in the legs. And so these people sometimes may have like May thinner. Can you explain that real quick?
Yeah, so basically, as I mentioned, all these veins, superficial veins out in our legs, they ultimately drain into our deep veins, and then the deep veins come up through our iliacs and into our IVC. And the way everyone's anatomy is the artery lays on top of the vein, and particularly on the left side, although you can have narrowing elsewhere, particularly on the left side, the left common iliac vein gets compressed by the artery, and so that you are at risk for DVT in the left leg, and you are at risk for venous insufficiency and varicose veins. So you have to have an index of suspicion to look for that. And what we typically do for that is we can get a CT. There's 2 types of tests we can get. We need a contrast-based test. It's hard to get an ultrasound up here. We can get a CT scan or a CT venogram that looks at the veins. And alternatively, one of the things that is advantageous, and we can look at pretty much all, is it's minimally invasive procedure, but we do get access here. We put a catheter and are able to take pictures of all the veins in one setting. And if that narrowing does exist, we can potentially treat that. The other advantage of that is we can do intravascular ultrasound. So sometimes when you're looking at it on a CAT scan or you're looking at it on a venogram, the vein may be narrowed, but it's squished. So when you look at the contrast, it looks wide. When you think it's wide open, it's not until you put a catheter inside with an ultrasound and really see that constriction that you can really see. And so, that's why it's just important, again, to be knowledgeable about that. And when you're in the office, you might, like I said, you might have a patient that's complaining of only left-sided symptoms. Oh, I've had ablation in the past, it's not better, it got worse. And there might be something central going on, so it's important to not miss that.